Good evening, everyone. I'm LaShondra Little, and I serve as the chapter president for the Atlanta Suburban Alumni Chapter of Delta Sigma Theta Sorority Incorporated. I'm so excited that you all have joined us tonight as we continue our monthly mental health webinar series. And today, because it's Mental Health Awareness Month, we're going to sit back, relax, and have a candid conversation with everyone. We won't have a set topic per se as we've done in the past. We just want to give everyone the opportunity to just discuss mental health, and especially as we think about mental health in the Black community. I reached out, speaking with Soar Sabrina Clark, who's our physical and mental health chair. We wanted to talk about doing something different this year. And so mental health being something that we really haven't touched on as much as we should, we decided to really focus on mental health, and creating this webinar series has really been a blessing. It's been reaching people each month, and we've been getting a lot of great feedback. And so hopefully it's helping to really silence that stigma that is around mental health, that allows people to sort of sit and suffer in silence. So hopefully this series will continue to bring people together to speak about mental health, to really seek out help. We've had great professionals each month that have been giving out great information, and we have some great professionals on hand tonight that will be introduced that will really give you all opportunity to ask questions. You're in a safer environment, so don't be afraid, don't be shy, ask whatever it is you will want to know tonight, so that if it's going to help either you or someone you know that may be suffering, that you will be able to get that question asked. So again, thank you all so much for coming, and I'll turn it over to Nadia Barnett.
Thank you very much, Soar Little, for welcoming our guest tonight. I want to share with you some housekeeping tips for this evening. Please use the Q&A function here in our Zoom webinar to ask any question related to mental health that you may want to know. In addition, if you are watching this live on Facebook, please utilize that avenue to also add your questions in, and we will make sure that we will add them to our list so that our panelists can get to as many of them as possible. For our moderator this evening, we have been graciously awaiting her presence on this series, and we have with us Sora Vivian King, who is an author, speaker, communications expert, and connector who helps us find and share our voice by leveraging media, moderating with confidence, and motivating us to boldly share our world-changing messages with our communities. She is the founder of the Vivian L. King Connections, LLC, and she wrote a book entitled When the Words Suddenly Stopped, Finding My Voice Again After a Massive Stroke, which is on Amazon and a bestseller. Please go check that out. Ms. King is a top finalist in the Global Author Elite Awards for 2020. She's also a professionally trained voice actor and moderator, and often participates in workshops and forums. She has an extensive career in journalism, public relations, and community relations, and we are so happy that she is here with us today. I'm going to now turn it over to our moderator, who will introduce our panelists and get the conversation started. Our Sora Vivian King.
Thank you, Sora Barnett. It's a pleasure to be here this evening. And regardless of what Sora Barnett said, like the main reason I'm so excited is because I'm here really on behalf of Tunnel Light. And Tunnel Light Incorporated is a nonprofit that I serve on as a board member, and one of my fellow board members and my cousin, full disclosure, put me together with Sora Sabrina Clark about this particular Mental Health Monday series. And so it's something that we really want to be involved in because we care about mental health. Our vision at Tunnel Light is a world where individuals and families impacted by mental illness, regardless of color, creed, background, and environment, seek the help they need without worry of stigma. because we know it is such a stigma, especially in our community. So I'm really excited to be here today and to really learn from this distinguished panel that we have. So I'm going to get right in and start to introduce them. But keep in mind, after you hear from them, we have questions. I have questions, but we want you to ask your questions, as Sora Barnett said as well. So I'll ask some questions and you just put yours in the chat whenever you feel like it, and we'll get to as many questions as possible. So let's start with the panel. First, we have Tammy Brown. Now, Tammy lives in Atlanta, but she is a New York native. And so she has more than 15 years of combined experience in advocacy, community and stakeholder engagement, and program design and implementation. Right now, her current role is Senior Behavioral Health Program Manager at Peach State Health Plan, where she serves on a team responsible for the behavioral health operations for the state of Georgia. She has experience in various healthcare settings, working with multidisciplinary teams and collaborations with multiple agencies, such as the Georgia Department of Behavioral Health and Developmental Disabilities, the Georgia Department of Community Health, and several community partners. She is a national dual certified mental health first aid instructor through the National Council for Behavioral Health. She is also a CIT crisis intervention training instructor. She has given back to the community as a volunteer for a number of causes. Bottom line, she cares about the community. Miss Tammy Brown. Next, we have S. Candy Winfield, who is a licensed professional counselor, a national certified counselor, distance credentialed counselor, and has been in the field for more than 20 years. She has a master's in clinical psychology and completed graduate work at Richmond University formerly Psychological Studies Institute, I should say. And at Richmond, she studied the integration of psychology and theology and received a diploma in Christian counseling. So we're going to get into that today as well. She is a skilled trainer, lecturer, and workshop presenter. Candy has presented for the Georgia Department of Human Resources, APS Healthcare, and numerous ministries. In addition, she is credentialed as a facilitator for the following programs: the Prepare Enrich program, a premarital marital curriculum, CISD, and currently studying integrative medicine for mental health. S. Candy Winfield. And last but certainly not least, we have Dr. Sean L. Garrison, who is the Director of Counseling Services at Morehouse School of Medicine, serving the students of 5 academic programs and residents from 7 specialties through counseling and teaching for the past 30 years. She doesn't even look a day over 30. She holds a faculty appointment at Morehouse's Department of Psychiatry. She serves on pivotal institutional committees and plays a central role in study skills, time management, stress management, and learning communities for all academic programs. Her teaching duties include cognitive behavior therapy and psychotherapy 101 in the psychiatry residency program at Morehouse School of Medicine. Additionally, she provides clinical supervision to psychiatric residents learning the art of psychotherapy. Dr. Garrison offers direct clinical services to patients in the Georgia Cancer Center of Grady Memorial Hospital and Atlanta's general population through Morehouse Healthcare. So I know that all of you out there in the audience, please give them a round of applause because they are phenomenal. So I want to just start off with kind of setting the stage, if you will. We're here and we all know that mental health is such a stigma in the African American community. And let me just let the audience know we're having a conversation. And so we're just, it's like we're at the kitchen table or we're in the lounge in the living room and we're just having this conversation. And so somebody may get inspired by something somebody else says, and that's how we want your questions to come in as well. So you're kind of eavesdropping on this conversation. So ladies, why is there such a stigma with mental health in the African American community? Whoever wants to start, just jump in.
I think we, for a long time, have just come accustomed to not talking about things that are unpleasant or that are not nice. And mental health kind of falls in line with that. We don't address it, and it's just been customary not to talk about things that are unpleasant. And so what has gotten attached to mental health and counseling, and particularly therapy, is that if I go, it means I'm crazy. That's the first thing people say is, oh, I'm not crazy. I don't need to go to counseling. And that is not what counseling is for. And so we have to remove that stigma. And I always use the analogy that when you break your leg, you go to a orthopod, you get a cast, you walk on crutches, and you allow it to heal. Well, the same thing with our emotions, our broken hearts, our losses, is that we go to therapy, therapists, psychiatrists, psychologists to help us heal. Those are the crutches that we use until we heal. And so we have to kind of just remove that, and that counseling is okay, because our emotional health needs healing in the same way that our physical bodies and physical ailments need healing.
Absolutely.
Yeah, I would say African American community is still big on listening to your elders, and our elders definitely come from the the mindset that has already been mentioned, but we haven't had a whole lot of time, in the United States of America, to have the luxury of, or what it feels like, the luxury of being the worried well. But that is a misnomer, because we really do have a lot of stress and a lot of reasons and a lot of deserving to get healthy, just like everybody else. So I normally think about it like in 4 ways. The first one is the things that keep people from talking about mental health or from getting help is that, first of all, it's already been mentioned, your faith ought to be strong enough. And if you need to talk to someone else, or if you need to go to some mental health professional, then you just don't believe hard enough, or you're not listening to God, or maybe this is your punishment. So that's one thing. It's like your faith is supposed to be covering everything. Another one is the whole, don't put your business in the street. Don't you be going telling somebody you don't know about all that stuff happening in our family, because you need to go talk. Don't do that. There's also a real distrust still of the medical community, which is well placed. But there's the idea about, and don't be swallowing no pills and white folk be giving you either. As well as, we still have that sense if you go to a doctor, they may or may not help you, but we generally don't trust the medical community, especially when it comes time to try some sort of treatment that we haven't heard before. So I think all those things coming together keeps us in general from taking care of ourselves. And this whole, I'm not crazy. We forget, I love it that, if you got your broken leg, we forget that everything is on a continuum. You don't have one point where you're healthy and then 2 inches over, now you're crazy. Like, that's not how it happens with being physically well, being overweight, it's not any of that. So Black people in America have a lot of reasons to have some fear-based decisions, but it's still killing us.
You brought, go ahead, Tammy.
And just to add on to what has already been said, for many years, Black people has been used to carrying a lot of weight on our backs. We're used to being the strong Black woman and the strong Black man. We've had to fight and just deal and cope so much over the years. We just figured that this is something else that we should just deal with. And whatever it is that we're going through, whether it's physical or emotional, it will come and it will go. But we're learning that that's not always the case, right? Some other issues with stigma in the Black community is access to care. Not necessarily, kind of access to care. It's kind of perceived in the Black community that, why would they give this sort of treatment to me? Who am I? Or if they do, as piggybacking off of Dr. Garrison, why should I trust them? There's a gap in behavioral health professionals, not only across the state of Georgia, but, across the nation. there need to be more of us. And not only do there need to be more behavioral health professionals, there need to be more behavioral health professionals that look like us so we can trust each other when we do go seek out treatment. So those are some things. And another thing is we think it's going to cost too much, right? When we think about behavioral health and psychiatry and psychology, we think that this is some sort of specialty treatment that's been afforded to white folks all of these years, so we can't possibly afford it. But that's not necessarily true. And there is definitely affordable treatment options out there that I'm sure we're going to get into a little bit later.
Yep, absolutely. And, just what you all were talking about, just what we've been through over years, but even just this past year alone has everything that has converged, with the pandemic and with the social justice and just reaching a fever pitch. Somebody mentioned the church. And before we get into definitions, how has the church, how do you explain to someone that seeing a therapist is okay, even if you are spiritual?
I'll address that a little bit. I think there has been the mindset that if I am spiritual or in church, I'll talk to my pastor. One of the things that I have done a lot is to educate within ministries that we can coexist and that we can work side by side, and that my specialty in terms of clinical psychology and a pastor's specialty in terms of theology and spirituality can, again, exist side by side. And so people have to be educated, I think, in terms that one is mutually exclusive of the other, and that we can, part of why I became a counselor was because of the ministry that I was in. And just to give you a short story, there was a woman in the ministry that was delusional and thought that one of the deacons was her husband. And she planned a wedding, sent out invitations. And on the day of the wedding, we actually had to post security to turn people away. She had mailed out 300 invitations. It touched me so because, and this is over 30 years ago, I was in love with the same deacon. And my thought was that could have been me. And we met with her, we prayed with her, we talked to her, and there was nothing that could reach her. And that's when it came clear to me that I can pray all day with someone, but if there is serious mental illness, there needs to be another level of intervention. And that's when I sought out to seek a program that combined clinical psychology and biblical principles, because you need both. I believe you need both.
Absolutely. Dr.
That's so interesting. Oh, yeah. You just said so many things in that. I don't have the specific training of theology and psychology. Throughout my process, I've become much more spiritual and a whole lot less religious. And so what I've noticed is that even in the most progressive churches, sometimes it's hard to get the message across to the congregation that listening to your therapist is not being disloyal to your pastor. And also, but honestly, it is difficult to recognize that the pastor may not actually be the final word, may not actually have all of the answers, and that there isn't one place where all the answers are. And I think that that's where we still struggle. At least I noticed in the churches that I've been a part of, to the first one I grew up in, the second one for so many years, is that at some point it is difficult to feel comfortable with your own journey of discovery without feeling like you're being disloyal in some way. And that I can see that trend changing. I can definitely see it changing. But I do know that that's one of the things that makes it hard. I love the new way that seems to be coming with church and church members and younger people asking questions and wanting to be a part of things and saying, this needs to make sense to me. How do we put this together? And really pushing to hold both things, their mental health and their spirituality and their religion. And I think we're going to end up in a good place, but there's always growing pains.
Absolutely. When I think about the church and any types of illness, whether it's physical health or mental health, sometimes the church has to play catch up, right? Because this same sort of stigma with the church and mental health, they thought the same thing. You know, when I was growing up, it didn't matter if a person was diagnosed with HIV or cancer or whatever it was, it had to be prayed away. And somebody had to lay hands on you and everything was going to be okay. Right. And it took the church a while to kind of catch up with it's okay to have professionals there to help as well. And so that's kind of where we are in terms of behavioral health with the church. The good thing is the churches, they are getting more on board with behavioral health. They are reaching out, they are asking questions, they are having a lot of well, I don't want to say a lot, but there are some churches that are going as far as getting mental health first aid and any other type of clinicians involved in their church. So their congregation can have access to just someone to talk to. I'm very proud. My aunt is a reverend in upstate New York, and she did a special sort of certification where she has a mental health something. I don't know what it is. Don't get me to telling stories. And then my stepdad is a bishop in upstate New York, and he is just starting to do a lot around mental health and mental wellness. And my grandfather, who is a reverend in the country here, I'm not sure if you all have heard of Cuthbert, Georgia, but my grandfather is 86. And he started asking me questions about behavioral health this past December because so much was going on with COVID, and he started noticing some things with himself. But he started asking me questions, and now they have counseling now that they've started to slowly integrate back into the church at the church. But we have been getting so much in terms of the behavioral health professionals. They want to know, the church wants to know, they want to be involved, and they want to have this resource for their congregation. So it's really good to know that they are with us as allies.
That's fantastic. Candy Whitfield, I also want to tell you thank you, because if you're the one that's also spending time educating some of our clergy about how these two things go together, my hat's off to you. And I'm ever so grateful for that, because I know that's sometimes a journey.
It is. And churches are open. I have been a resident counselor in ministries where I go early on in my career. I would spend a day at a ministry, and the congregants were able to come for the services free, and the church paid me. So things are trending in the right way, and they are open. So I think things are changing. We just have to let them know that, again, they can coexist, and it's okay to seek counseling.
And this is just purely me, but I think you may agree with me that, you know, God put this knowledge and your ability and desire to seek this knowledge in you for a reason. And so,
Absolutely.
you know, you could be the answer to our community's prayers. And I think you are. And they're just, like you said, Tammy, catching up.
Mm-hmm.
Yeah, I tell people, you know, you can't pray diabetes away, but God made it available eventually, insulin, all that, everything that we have here, but absolutely positively wasn't supposed to happen. My spiritual understanding is that it wouldn't be there. And so, you know, oh, I don't want to get a therapist. Well, why? There are therapists here. And, you know, I'm pretty sure me and God are straight. So I'm doing what I'm supposed to do. Yeah. So I'm supposed to be here for you. This is not, don't turn around and tell God, no, thank you for the resources that you're making available to me.
Yeah.
Absolutely. Thank you. Let's kind of get into some definitions. You know, probably a lot of people have heard about bipolar. A lot of people may have heard about schizophrenia, and there are many, many others. What is the difference between those two, and what are some of the other illnesses that we need to look out for and be aware of?
Should I start out with this one, and then we can all take turns?
Okay.
Yeah.
Go ahead.
Yes. first, I would just like to explain that there's just general categories that we like to think about. There are thought disorders, and then there are affective disorders, disorders of your emotions. And there's a whole bunch of other stuff in DSM. And then within those two general categories, there you can also have symptoms and signs of the other. For bipolar, that's an affective disorder, I'm pretty sure. Let me just give you all a disclaimer. I am a clinical psychologist, and interestingly enough, I absolutely positively hate diagnosing people. I don't like putting people in categories. I don't like putting them in boxes. I work at Morehouse School of Medicine. That's a medical, biomedical place, and there's a heavy reliance on what box to put a person in so we know what pill to give them, and I'm not really feeling any of that. So I will be speaking generally, and I will rely on my peers over here to flesh this out for me. But thought disorders basically are those where a person has a glitch or a break or a strong dysfunction in reality testing. That means you just really have a hard time figuring out what's real and what's not, what's actually there and what isn't. The affective disorders are more those that are, depression, the highs, the lows, and anxiety disorders. Obsessive compulsive disorders and anxiety disorder, because you're doing all these obsessions and compulsions to manage the anxiety. So the thought disorders we consider generally to be a little bit more difficult to manage because your reality testing is broken. It's hard to stay connected with things. However, with some of the affective disorders like bipolar, which there's more than one form of bipolar, but the one that has both swings, when you get on the up, the very high up, which is manic, you can also have some reality testing problems. You can, get very manic, you can get very grandiose, you can think, hey, I can do anything, but that is a part of the swing. It is not generally consistently there. On the lower end of depression and people's general depression, you can also get some reality testing problems there too. Oh, the life is awful and horrible, nothing is going to go well for me, and that you cannot really see that life isn't the way that you see it. Schizophrenia is a thought disorder. And I will say that there's some new thinking about schizophrenia in Black people, quite frankly. But the way we think about it traditionally is that it's a pretty strong thought disorder where you really have difficulty keeping your reality testing intact. And there are different kinds of hallucinations. You can hear things that aren't there, theoretically. You can see things or even smell things that are not there. So somebody fill in, what did I miss? What did I?
One of my bucket list items in terms of my career was to work at Grady. And Grady has a psychiatric emergency room, which is kind of unique in terms of emergency rooms. And I worked 5 years in that psychiatric emergency room. And one of the, probably 50% of the people that come in say, I'm bipolar schizophrenic. And those are two, as she just explained, types of disorders. One is a mood disorder, and again, one is a thought disorder. However, we hear all the time, I'm bipolar schizophrenic. Even though those are two distinct disorders, sometimes those symptoms can coexist. And that disorder is called schizoid affective disorder. So it is a combination of the mood disorder and the thought disorder. And so when we are dealing with mental health, there is a whole range and spectrum of how symptoms kind of manifest. But typically, and the other category is substance abuse disorders. And of course, we have all been impacted and affected by that. And so there are, as she says, different areas that kind of fall under mental health. Primarily, again, the anxiety disorders, which ranges from everything from OCD to panic attacks and anxiety attacks. Agoraphobia, which is the fear of even going outside of your home. Tic disorders, where you're pulling your hair out or scratching your skin. So there are a whole myriad of disorders that kind of fall under mental health. And then we haven't even touched on adolescent disorders. That is not my area. I work primarily with adults, so someone else can address that. But again, there's a whole range. And so I'm wondering, are we getting some questions from our audience in terms of areas that they would really like us to delve into and talk about in terms of disorders and symptoms and treatment for that? But I wanted to address that bipolar schizophrenia because that is
Right.
one of the things that people always say, oh, I'm
Right.
bipolar schizophrenia.
Well, and it's not like they're making it up, because for
No.
at Grady, I'm sorry, Tammy, at Grady, there's lots of people that tell me I'm, bipolar schizophrenic, and it's because they've heard it. And I do need you to understand that, physicians want to put a label on you so they can figure out what medicine to give you, and that they can put you in a category, which also does translate into financing dollars, funding dollars at some point. So, and schizophrenia and bipolar in the big blooming thing are more intense or more severe categories that you can be put into, which people of color normally get put into.
Yeah.
Historically, many Black people don't get diagnosed paranoid schizophrenic. And you know why? Paranoid schizophrenic people are very smart. Like, they, generally speaking, they have a lot of stuff going on in their head. So you don't see that a whole lot, at least not when the diagnosis person came out. So I also, want to say that you've heard it probably, but then you need to be very careful about what that actually means. And the last thing is, just because something looks new and different and strange to you doesn't mean it's not manageable. Many of these things, even at the extreme end of things, are quite manageable. I'm sorry, Tammy.
Oh, no, it's quite okay. Thank you so much. I wanted to piggyback off of what Dr. Whitfield said, and you too, Dr. Garrison. Many times folks say I'm manic depressive, or I'm bipolar schizophrenic, and that is what they've heard. And just for the folks in the audience's sake, oftentimes those people have been in treatment and gone to several providers over so many years of their lives. So when they go through these different providers and they get these different diagnoses at these different providers, one provider may say schizophrenia, the other provider may say bipolar disorder, and it could be a lack of knowledge, hopefully not on that provider side, but they are human, right? But sometimes it takes a while for an accurate diagnosis to be made, and unfortunately, once that diagnosis is there, it's kind of there. So, that's just something that we definitely want to be aware of. And sometimes illnesses, whether it's a mental illness or a physical illness, they can graduate into something different. So we just want to be aware of that too. It can start out as one thing and it can, exacerbate into something different. So, if your loved one or a community member may have be diagnosed with a particular illness, it does not mean that it's just going to stay that. It could, but it may not. So I think this is a really good question, because oftentimes, we are asked about, as clinicians, we're asked about depression and anxiety often, and rightfully so, because depression and anxiety, those are the two most known, and those are the top diagnosable illnesses, in the United States. And actually, that's international too. So there's less prevalence of bipolar disorder and schizophrenia, and we need to talk about that more. We need to talk about those illnesses a little bit more than what we typically do. So that's a very good question.
I know somebody in the chat said, what is the difference between thought and psychotic disorders?
Thought disorders are kind of more associated with neurology. Psychotic disorders are typically more linked to psychosis, where it affects, it depends on the severity, intensity of whatever the psychosis is, and how that exacerbates and how it develops over the years. And it could really affect a person's living situation, their job. It can be really debilitating. There are instances where your mental illness can be as debilitating or more debilitating than a physical illness. So I'll kick it over to one of the doctors to add on to that.
And psychosis also kind of refers to out of touch with reality. And so it has, as previously mentioned, psychosis can take the form of a hallucination. There are several types of hallucinations. As mentioned, you can have a visual hallucination, meaning that you see things that are not there. You can have an auditory hallucination, meaning that you hear things. And again, to keep in mind that psychosis is usually going to deal with your senses: sight, touch, hearing, smell. You can have a somatic hallucination, meaning that you feel things within your body. Tactile hallucination is the sense of touch, that you can experience that things are crawling on you or in you. So there are different types of hallucinations. That is a type of a psychosis. But basically it means that you are experiencing things that are not there. And it's real to the person. They see it, they hear it, they feel it, they smell it, but no one else does.
Right. Sometimes thought disorders, psychosis can fall under certain thought disorders as well. Yeah. So, and then the tactile hallucinations that have been brought up are to be distinguished from going through DTs with substance abuse things. And people do feel ants crawling or something, and that's not necessarily the same thing as psychosis, although at the time they are very close to being psychotic. Also, under the thought disorders, there's also these things called delusions, which I like to think of them as like real walled off lesions in the way that your reality testing works. So a person can make sense and all kinds of other things, but you get to this one thing right here and they're going to be off and running. You cannot explain it to them that just doesn't make sense. There's a delusion. And sometimes some anxiety disorders involve delusions because they need to think or believe a certain thing that just creates the anxiety. It's hard to move. It's hard to move that. Mm-hmm. So you can see that all these things sound complicated and confusing. I hope we haven't confused you more, but what I want you to understand is that the way we have been built truly is wonderful and fearful and amazing. Our minds can do so many things, and all of this is housed within how we work. So this is more to say how we don't understand some things versus, oh my God, something else to be afraid of. I do want to add that because we're constantly learning things. Right. There was another question about a family member in the Q&A who was bipolar and scary.
Yes. And here it is. I was going to say, I don't think you're confusing people. I think the audience is coming in with their questions. And so the question is, so much of this exists in our families. It's so sad that these family members get ostracized. I would like to understand bipolar mood disorder more because I have a family member with that, and I think she has schizophrenia as well. Can you speak a little more on this? Her behavior can be scary sometimes, if I'm honest. And we want everybody to be honest here. Yes, absolutely.
Again, there is a diagnosis called schizoid affective disorder, meaning that you also have the psychosis, but you also have the symptoms of schizophrenia, which is out of touch with reality. And again, kind of going back to psychosis, psychosis can exist all by itself, or it can be drug-induced. It can be a part of depression, a severe chronic depression. You can have an episode of psychosis. And so psychosis, again, out of touch with reality, the hallucinations and delusions can exist with a other mental health disorder, or it can exist by itself. When we see, again, the psychosis and the bipolar existing together, typically that is a person may be diagnosed as schizoid affective disorder. The affective meaning the mood, the schizoid meaning the psychosis.
And to piggyback off of Dr. Whitfield, and also what Dr. Garrison said, it's amazing what our minds and bodies can do, right? Because sometimes after pregnant moms have birth, they can experience some psychosis, right? And they haven't done any drugs or anything like that in the absence of drugs. There has been times when if we don't eat enough, if we're not nourished enough, we can start experiencing some psychosis. So we just want to be aware of those things. And And something important for you all to take away is because a person may experience psychosis, it does not mean that they are in a psychotic state 24 hours a day, 7 days a week. That's those that are a little bit more severely, with more severe diagnosis, but it is perfectly within normal limits for a person to be diagnosed with bipolar disorder or schizophrenia, and they have, just like Dr. Whitfield said, episodes, and they may not experience any of those hallucinations or delusions or psychotic states for weeks. Some people have it every day, some people have it every other day, some have it every other week, some may experience it every few months, or they may be in remission and don't experience any psychosis for a year or two. So we just want to keep that in mind as well.
Yeah.
Not that for her other question, which is kind of scary to her, I would caution us to remember that we are all still human beings, though, whether we have some psychosis, a psychotic break, a first one, or some delusion, and that you can be in the room with someone and feel if they're basically still in there if you don't succumb to your own fear about something being different. The way I would put it from street terminology is, is some people who are crazy, and then there's some people who are crazy and dangerous. Crazy is good. We can work with that. What's going on? What do you need? But dangerous, that's another thing. And generally, if someone is dangerous, it's because they too have been caught in their own web at the moment and are not able to stay safe. It is rarely true that someone purposefully is deciding that they need to hurt somebody. Even those persons who are dangerous, they are having hallucinations, telling them to do something, and they've been fighting those for a very, very long time. So I would like to say that it would be good to assume positive intent, even if someone looks unusual to you. Then the other thing is to understand that if someone does need some help and you're in their environment, either you can help them get to a place where there's help, or if you're feeling overwhelmed or unsafe, then you have to leave because they got to work on this. And, it's interesting. I want to make a parallel. Sometimes now in America, it seems like all of a sudden white people understand what it's like to be Black. But, that's been us like for forever. It's the same thing with people who have been working with mental challenges. We may just be realizing, oh my goodness, like you got this delusion. Oh, now it's starting to break through. But they, however, have been managing this, working with it, trying to stay involved with you and the family for lots longer. So give them credit for that. But remember, we're all human beings, and you follow your instincts as long as you are not acting out of fear or judgment. If you feel unsafe, honestly unsafe, you may be, and you need to get yourself and that person safe. If you're just confused and surprised, okay, that's a different thing. And that is a different line of problem solving.
I know we've got lots of questions coming in, but I do want to kind of pick up on something Tammy said, that sometimes if we're not well nourished, it could lead to something. So my question is, what causes mental illness? Where does it come from? How does it develop? How can you pinpoint that, or can you pinpoint that?
Right.
So there's some stuff. I'll kick it off, and I'm sure we all have feedback for all of these questions, right? Because we're all so passionate about this work that we do. And I'm so grateful to be on the panel with these two doctors. So I'll kick it off. So sometimes it's hereditary, right? And if it is hereditary in the family, then there's going to be a greater chance that the offspring or the siblings can also be diagnosed with a mental health condition. Then there's also situations where it may be dormant. And something as simple as, my brother, he went off to college. He was a star athlete and straight A student. He never touched a drug a day in his life. But then when he was at a college party, his first year in college, he smoked weed for the first time, and he hasn't been the same since, right? We don't know kind of where this came from. Then there's also going to be some environmental factors, trauma. Trauma is a big deal. What goes on in a person's environment is a really big deal. And it can contribute to what we feel emotionally, and that could travel to our brain and unfortunately, sometimes we do develop mental illness. That's just me kicking it off.
And I want to say, I don't know where to start with that. So yes, we all have proclivities for certain things that will happen for us given the right amount of stress, both environmental and personal. Like my way may end up being more of an anxiety kind of thing. Somebody else's way may end up being more of a depressed thing. So there is always the readiness for that in some way, but it takes so many things for that to happen. Even in the example of, smoking weed for the first time, that was in those situations, that's most likely a catalyst, but it's not the only thing, and it wasn't totally sufficient. That there had to be lots of other things that are going on. But the question of what was how do you know when someone is mentally ill or what causes it? Somehow that question sounded like maybe some of us are actually altogether okay all the time. Like we all have mental illness somewhere is what I'm saying. What makes you think that of us are not ill at some point in time in the way we want to talk about ill? Because we're all struggling with things. I'm glad. New Wave now, there's a book, The Body Keeps the Score, talks about how trauma actually impacts a person's development when it starts as a child, but certainly impacts the way you experience the world, your nervous system on trauma. And trauma is defined loosely, but one person's trauma might not be another person's trauma. But as people of color, we have so many ways to be traumatized in our own families, by family members. So I think that what causes mental illness would again be defined by what you decide to call mental illness. And if you're saying what causes the kind of mental issues that are disruptive to living, then it is a lot of what Tammy said. There are a lot of things that go into this. And in the West here, our doctors have this pathology approach. So they're looking for one or two things that's the problem. We fix that and it's okay. And that's rarely true. So we do have to keep pushing to understand the full picture.
Yeah. And I would just add that there is not one cause or one type of etiology that causes mental illness. Again, it can be a whole lot of different things happening at the same time or happening across a span of time. What is trauma for one person, as she said, is not necessarily trauma for another. I always think about Elizabeth Smart. And remember her, she was kidnapped and assimilated into the life with her kidnappers. And even when she was out in public, she did not say, "I'm Elizabeth Smart." And at the same time, there was a little Black girl that was kidnapped, put in a basement, taped to a chair with duct tape. And this little girl, at the time, she was the same age as Elizabeth Smart, somehow bit through the duct tape, broke a window, climbed out of the basement, and got away. Same trauma, handled totally different. Yeah. So again, it's almost a case by case, I think, in terms of, your heredity, your background, a lot of different factors play into it, but there is not one thing we can point to in terms of the etiology or the cause of mental illness.
I like what Dr. Garrison said, that there's kind of a fallacy with the question, because who's to say we're not all, we all have some sort of mental health issue. And so, at Tunnel Light, we think, that we need to make sure that just like we go to see about diabetes or any other chronic illness, we need to find out, have a mental check at least once a year, if not more. And would you all agree with that? I see.
Absolutely.
Right. And I would also say that we get mental checks all the time. We may not pay attention to them. We talk with our girlfriends, we talk with our family, and they'll say, "Girl, you know what? You need to pull up on that." Or, grandma might say, "Baby, I have seen this 2-3 times. What you doing?" But we don't listen to that, I think. But it also is, in addition to that, good to go to an objective source But mostly if you feel something. I did another panel thing with the residents, and somebody asked, how do you know if you're depressed? Like, well, if you're asking the question, something's going on. And that's the first step right there. I want to give us time, but I saw another question about a 5-year-old who was I think hearing voices or talking to someone. And I would be so interested to hear it with my other panelists, because a 5-year-old hearing voices may not necessarily be psychosis or not. And this is where my spirituality comes in. I mean, is he not hearing the ancestors? I don't know, or she. It depends, but it talks about how you can't take one symptom and then try to completely understand a whole complex human being, even at 5. But at 5 years old, unless something else is really going on, that's a little difficult to see a psychotic experience in someone that young. I don't know, I'd like to hear from my other colleagues. So I would say pay attention, because 5-year-olds are still working out their imagination as well. What do you all say?
Right. The question is,
Absolutely.
at what age can you experience psychosis? I have a 5-year-old student who is hearing voices. And I was going to go to that one next. So I'm glad you picked up on that, Dr. Garrison.
And it depends, each individual has their own individual experience. So, like it was already mentioned earlier with both of the doctors, we have to take a holistic approach. So we can't just look at one symptom and just say, hey, this is psychosis. We have to look at perhaps if there are any developmental or cognitive delays. As Dr. Garrison said, this child is still growing up. This child may still be talking to their their imaginary friend. And I do believe in the spirits too. So, I mean, this child may be talking to an ancestor, but the most important takeaway that we need to keep in mind is really just to monitor behavior. We want to rule out some of the things that I just said. So we do want to go for assessments and do talk to your pediatrician and do monitor your senses, your sleeping, your eating, your concentration. When I say I'm talking about this 5-year-old, and just really keep tabs on it. And if it exacerbates, then we definitely want to take those further precautions.
And when someone is in front of us, we are gathering a history. We do a social history, we do a medical history, we do a family history. Sometimes it's necessary to talk to family members. So it's not that someone comes in and says, I hear voices, and they get diagnosed with schizophrenia. And so it takes a conglomerate of information to come up with an accurate diagnosis. And then sometimes it's not accurate. So it's like we have to take a picture of what's happening at this time, but we also need to know what happens over time and what has happened before they showed up, to really get a clear picture of what may be going on with an individual.
Sure. And
Dr. Whitfield. Go ahead, Dr. Garrison.
In all honesty, my first thought, we didn't say it, but I'm assuming you're supposed to ask the little 5-year-old who you're talking to and what are they telling you? Because a lot of if it's good and wonderful and positive things, that's not nearly as bad as this little kid saying somebody's telling me to go get a knife and cut my daddy's toe off. I mean, you just want to ask about that. Mm-hmm. And then in all honesty, my thought is that at 5, it's one of 3 things from my perspective, and I don't deal with children, so everybody needs to take that into account. It is the imaginary friend, or that they're just working something out. They actually are still connected to the other side, and they're getting talks and conversation and protection, and or they are coming from a really traumatic place, and then you are seeing that this is what else happens, because this is how they have to make sense out of it to find themselves to be safe. That's just, the way that I'm thinking. But what I will say is, the first thing for that person, you have to ask the child, what's going on? Who are you talking to? What are they telling you? How do you feel about it? That's just basic questions.
Yeah. Which kind of brings up, somebody mentioned proper or diagnosis, getting the right diagnosis. And so we had 2 questions from Facebook, like what are the steps for getting a proper diagnosis? And then can you address the importance, when it's important to introduce medication versus therapy alone?
What was that first question again?
what are the steps for getting a proper diagnosis?
That's an interesting question. So I'm going to say this in two different ways. So the steps for getting an assessment, for a behavioral health assessment or a psychiatric assessment, the family can either go through their pediatrician, they can go through their own PCPs, their primary care doctor. A referral can essentially come from any place. If you think that yourself or a loved one or a community member or someone like that, if there may be calls where an assessment may be needed, then it's pretty easy to get an assessment. To get an accurate diagnosis, that kind of depends. You've been hearing myself and the doctors talk. You hear all of these very flavorful and onion peeling back scenarios, and it's not always going to be as simple as I'm going to go to this practitioner and I'm going to come out with a diagnosis that's 100% perfect for me. It doesn't work like that. Think about this 5-year-old we're talking about. This 5-year-old may get a diagnosis, and then in 10 years, that diagnosis may look different. Thinking about what Dr. Whitfield said, why are they calling me schizophrenic and bipolar? I got bipolar and schizophrenia. So, it kind of just depends, but really just staying on top of your own mental well-being. Go to those appointments because you have to be aware of what's going on with your body, and then the environmental factors and stressors and all of that stuff is going to compile on top of it, right? Hopefully we do have supportive friends and families and we're in a supportive environment, but there are times when folks just aren't. So I may have a diagnosis of anxiety, but things can happen. I may get pregnant and I may lose a child, and I may be 40 or 50, 45, and I'm still trying to have a child and I can't. Now some depression is starting to seep in, right? So it kind of just depends for each individual and their own life experiences.
Couple of people are asking about alternative interventions and what is available outside of pharmaceutical treatments.
Therapy, one. And I think when we talk about medication, really, as a clinician and counselor, I do not prescribe meds. Typically, it's going to be an MD, psychiatrist, nurse practitioner, or physician assistant that will prescribe meds. And also, when meds are prescribed, typically they're prescribed for a symptom, to treat a symptom or address a symptom, not necessarily addressing why the symptom is there. So you have to be very careful about medications. I mean, I'm not anti-medication, but I'm not, that's not my first intervention either. Because I think sometimes, things can be addressed without medication.
Right.
So when you talk about holistic and alternatives, getting to why the symptom is occurring. Sometimes the symptom is occurring not because of the situation or circumstance, but because of what you are saying to yourself about that situation or circumstance.
Absolutely. You can't get skill. You cannot get skill from a pill. So, but there are certain pills that can help you be more available to engaging in therapy and changing things. So really, Western medicine often, not so much now, but it's kind of like a hammer. So sometimes you might need a needle, but all we got is this hammer. So if there is something really big going on and there's a need for some fairly quick relief, then medication is well indicated. But it literally is like Dr. Whitfield said, it's relief for a particular symptom so that you can get to working on what else is actually the issue. But as Americans, we do want things to happen fast. Yeah. And if you are depressed and you happen to be 35 years old and you've been saying these things to yourself for the past 20 years, it really isn't going to clear up in a week and a half or even 2 months. You're going to have to learn. So there's a process. So we do have this love-hate relationship with, medicine and fast and, we want to be holistic, but we also have to understand that these things, the changes I think are more doable. They take longer, as they should. We are, lucky is not the word, close. to be in 2021 where when there is a big issue, we probably do have a pill that will help you with that so that you might be able to continue to move forward. So the other alternative things, honestly, is the mindfulness. You know, we're talking about therapy. We're also talking about down-regulating your nervous system some, especially with trauma responses. There's certain things that you can do to help yourself get over some particular issues. There's a thing called EMDR, eye movement desensitization, something or other, which involves using both sides of your brain to reprocess certain trauma. Trauma being nonverbal. By definition, all trauma is nonverbal. You know you're traumatized because you can't find the words to explain it. So that there are other ways to do that. And some of those things are very good. We also have to remember, that's one of the things where church comes in. We also have to remember that connecting with your community, where you don't have to work so hard to define yourself, is also important. And also connecting with something transcendent to you so that you can understand you are a part of something larger. All of those things are very important.
Absolutely. And just to give a few more examples of some alternatives to medication, there's equine therapy, the equestrian therapy, which is, you know, horse therapy. That's been very effective. It's data driven. So you can Google equine therapy and just look at the data statistics on that, the studies on that. There's yoga. We talked about mindfulness. There is meditation. There's acupuncture. So there's so many different things when we look outside of, you know, westernized medicine, which I'm not completely against, like the doctor said, but I'm not completely for it. There are some times when medication is absolutely needed 100%, but it's not 100% needed all of the time.
Correct.
So really, again, piggybacking off of what Dr. Whitfield said, if you're taking that medication to combat the symptom, but you're really not doing that talk therapy piece to get down to the core of what's causing that symptom, I mean, there's going to have to be some sort of balance there. But I just wanted to throw out some more examples of some alternatives for you.
And one of the questions said too, our loved ones can feel very isolated and they feel different. Are there any groups that offer a social element and not just a therapeutic component? So support groups.
NAMI, what is it? National Association of Mental Illness?
National Alliance on Mental Illness.
Not right. NAMI has groups. There's a group for almost everything. You just have to find it, right? Right.
Yeah. So there's your local community service boards, which are the safety nets for the state of Georgia. So there's a community service board for each county here. The community service boards, they have everything there except for physical health, but some CSBs may have some physical health, but they have your psychiatrist. Sometimes they'll have your psychologist. They have individual therapy, they have group, they have family, they have social skills for those who have a more severe mental illness, like those with some psychotic disorders. They have groups that cater to that particular population. They teach budgeting. They teach folks how to, just how to clean and maintain their home. So those are some basics that the community service boards have. And the community service boards, you can get treatment from them and services from them. You don't have to have insurance. So those are some. And then NAMI, of course, NAMI has all of those resources are at no cost to the community. So those are, for your family members, there are several classes, and I won't get into it because I know we have several more questions to get into it, but NAMI is another one. You have Mental Health America of Georgia, that is at no cost. Suicide has been on the rise for a very long time. There's the American Foundation for Suicide Prevention. There's a Georgia chapter here. They have several resources there. So, we could go on and on because, we have this information. So I'm always down to, give some resources. I'll share my email address and anyone can reach out and I'll give some extras. Because that's just the tip of the iceberg.
Yep.
And you can access the community service boards through your county that you live in.
Mm-hmm.
Every county in Georgia has one. And so whatever county you're in, you go to that community service board. So it'd be like DeKalb Community Service Board, Clayton Community Service Board, Fulton Community Service Board, etc.
We have a question. How do you begin the readiness conversation? And we talked about, you mentioned it before, ladies. I have a son who needs help and I don't know his struggle, but see his struggles. Every conversation, though, leads to an argument and I'm at a loss. Advice for this mom.
Well, I see Dr. Whitfield thinking about it. I know she's going to say something fantastic. Let me say that some of it, a good bit of it depends on how old your son is. If your son is 25, there's going to be something different than if your son is 17, which is different than if your son is 13. So it depends on where that person is. I have to remind us and parents too that we're responsible for our minor children, surely, but we're not actually in total control of how they experience the world, who they are, what they come here with a readiness for or not. So this is one of the hardest things because this is about having to realize at some point that not only as a human being or a pastor or a doctor, and surely as a parent, you can't fix everything. And so this idea about have the readiness conversation somehow sounds to me in the back that because I have to get him somewhere, because he must want to, somehow I can make him ready for this. And that's the problem right there. You cannot make somebody ready, but you can love them until they are, or you can love them to let them know that they're being ready to do what you think they should do does not predicate your love. And that's what's really hard. If this is a grown-up son, like, 25, interestingly enough, that sometimes that's even harder because you think you can reason with this person. Surely they would understand. But again, this is where I'm glad these two questions are coming up because this is also about setting your own limits and boundaries and self-care. That there's one thing about loving someone and loving someone who you're connected to and wanting to be helpful and nurturing versus fixing somebody. And we don't fix people. I've been doing this for a long time. My other peers have too. And no matter how hard we try, you don't fix somebody. I can also say this personally because I'm a very intense person. And if it was doable, I'm sure I would have done it by now. I have 2 grown daughters. I can tell you it doesn't happen. You can sometimes manipulate a person's behavior, but that is not fixing them.
Right.
Yeah. There's a kind of a related question. What advice do you have for individuals living with a person with mental health challenges who aren't open to treatment? I've implemented a safety plan, but what else can be done to help keep us safe?
Goes back to boundaries again. You have to make sure you're not enabling them to cause harm or put yourself in danger. Loving with boundaries, I say. And the boundary is the limit or the line that can't be crossed. And when they cross that line, there has to be a consequence that you stick to, because the consequence often is the teacher or what makes them realize that there's something that needs to happen differently.
And this is where earlier intervention is really key, right? Because the longer we see symptoms and behaviors in an individual and we don't address it earlier on, it's going to be much difficult for us to address those symptoms and behaviors later. When we think about behavioral health, we need to think about physical health as well. If a person has a sprained ankle and they don't get it looked at, it's probably not going to fix itself and it's probably not going to get better. It's going to start affecting that bottom part of the leg. It may come up to your top part, your thigh. Something might go on with your arteries and your nerves. I mean, I'm not a physical health provider. I'm a BHSME, so I'm trying my best to have the correlation between the two. But truly, that early intervention is key. If we overlook that early intervention piece, we're going to be doing our loved one a disservice. And then we're going to be stuck up having to pick the pieces up on the back end because we're being reactive as opposed to proactive.
But also, it just really is hard. We don't have a good safety net anymore for mental health issues. When we got rid of all of the community mental health centers, they got to be really hard. And so this safety plan is really important, and it has to involve crisis response. And the safety plan has to involve you being willing to do what feels like an extreme thing, because sometimes the way the situations we're being put in, you only have an extreme response that can be helpful. It's about safety. I'm
Yeah.
gonna have to step out 1 minute. My computer's about to die. I'll be right back.
Okay. I'm going to ask this question. It's specific about excessive alcohol use. What resources are available for an older family member suffering from excessive alcohol use when alcohol consumption has always been a part of their family's social dynamic?
Again, the person has to want help. If it's always been a part, and they don't see it as a problem, they're not seeking help, it's not excessive to them. That's what they want to do, and that's what they like to do. That's what they're going to continue to do. When it begins to negatively impact the household and other family members that are possibly living in the household, again, it goes back to consequences and boundaries.
Mhm.
Right.
But you can't make somebody stop drinking
Absolutely. And
or
in terms of,
using.
Well,
I'm sorry,
especially if
Tammy.
it's a huge
absolutely.
dynamic, especially
And,
if it's part of the family dynamic too, right?
right. In terms of resources, though, those are some of the same resources that we already shared. You know, your community service board that are available to all Georgians, regardless if you have health insurance or not. There's your NAMI. The department, DBHDD, the Department of Behavior, Health, and Developmental Disabilities, they have a particular department, if you will, that's specifically for the older adults. And so they have some specifics. I'm not sure how old this person is. I'm thinking specifically 60, 65, if we're talking about the Medicare population. So so those are just some resources. And we just want to keep in mind too that, you know, substance use disorder, I don't want to start diagnosing on here because I don't have all of the background information for this individual.
Right.
But what I will say is substance use disorder, it is an illness. It's an illness and it has to be treated as such. That does not mean that boundaries should not be put in place. Boundaries should definitely be put in place. But we have to, again, when we think about behavioral health, substance use disorder, try to think about a physical illness. We may have family members, loved ones who have physical health problems, and we've been begging them for years to go get treatment and to take their medication, because if they don't take their medication, something bad is going to happen and they may possibly die. But it is up to them whether they are going to follow through with those treatment recommendations or not.
Mhm.
Another underutilized access to services, particularly among African Americans that are employed, is your EAP program. EAP stands for Employee Assistance Program. And this is a benefit that is offered to employees from your employer that will provide free counseling services, but it goes way beyond counseling services. There's financial services, there's legal services. So if you're working for a corporation or any kind of large corporation, Home Depot, Coca-Cola, all the major employers, they offer EAP. And sometimes I have a client and they're working for a major corporation and they know nothing about their EAP.
Right.
Fulton County, all of your government entities offer EAP. So that is a service. And in terms of substance abuse, if you have a substance abuse issue and you work for an employer who has EAP and you go through your EAP program to seek services, they have to hold your job.
Mhm.
They have to hold your job.
It's confidential.
And it's confidential.
Right, it's
Absolutely.
confidential. A lot of people do not want to take advantage of the EAP because they do not want their employer and their business. It is completely confidential. Take advantage of it.
Yes, and it's free. It's free.
I want to say
Yes.
something about that alcohol thing. I think I was out, but I saw a question about, what about somebody that's had a long time alcohol problem?
Right.
And substance abuse, alcohol abuse, and alcohol is a substance. And sexual abuse, especially of children, are family systemic issues. Like, you cannot have somebody that drinks that much without the whole family colluding in some way or another. You cannot have someone having long-term abuses, especially sexual abuse, without the family system being arranged in some way that will eventually either allow this or communicate very clearly that this person feels unsafe, they're not supposed to do anything about it. So what I will say is that it may, especially on the substance abuse end, it may not be that identified patient that you need to get help from. It is a family illness. And so you go to Al-Anon or NA, Al-Anon, what's the other one? I think it's Narcotics, aka and Narcotics Anonymous, NA, that there is a family aspect of that. So that's Al-Anon. There are also, because it is a codependent system, and that if you're in that system, you also need to recover. I know that's probably not very fun to hear. But I come from a family of alcoholics and drug addicts. Depending on the year and the family reunion time, half the people in recovery, half the people are using. It just depends, and it switches up. So I know what I'm talking about. That you need to be aware of that. And if you are uncomfortable enough with what's going on in this family system, you might get some help for yourself. Again, setting some limits and boundaries and talking about self-care.
I want to get to one more question, the last question in the Q&A before I ask you guys to give us one takeaway, the last thing you want to say. But can you speak to available treatment options for anxiety other than medicating? And I know we kind of talked a little bit about that earlier, but I think maybe this audience member may have signed on late or needed some extra discussion around that.
Dr. Whitfield already alluded to this. Cognitive behavior therapy is most effective with depression and anxiety issues. So therapy is very helpful with that. You do have to be willing to go to therapy and to work hard at it. Anxiety is particularly difficult because it is about your belief system that is beating you up. But I mean, I think therapy is one of the things that one can do in addition to the other things we talked about, meditation, the therapies with both horses and water, anything that down regulates the system. That's what I'm thinking. Guys, what else?
I agree. Cognitive behavioral therapy would be my first intervention, even before medication. I mean, if you're having panic attacks and, again, we sometimes have to address that through medication. But I've had clients that have had multiple panic attacks in a day and addressed it and diminished them without medication. So CBT works.
Great. We have one comment. Someone said we also must encourage those who have suffered trauma, rape, abuse, death, witnessing others' trauma to seek help as well. NH is not only depression, but schizophrenic PTSD is a real problem in our community. Oh, MH, a real problem in our community. Mental health. Thank you so much, Cherie. So we're about 6 minutes away from the end of the hour. So we've had a rich discussion, and I just thank you for all of your comments and just your candidness. What do you want to leave this audience with?
This past year with COVID, I kind of jokingly say we have all been traumatized.
Yeah, we really have.
Yeah, we have. We have all been traumatized. And because of that, we all need to check in with ourselves and make sure that we're okay and do what's necessary to be okay. And sometimes that means therapy. Sometimes that means just having a support system. Sometimes that means being able to go with the flow and not be so rigid, because those who have a hard time with change had a hard time because everything that we know changed. And so a takeaway is that sometimes you just got to go with the flow.
Agree.
Be intentional. be very intentional about the education that you want to seek for behavioral health, inclusive of mental illness and substance use disorder. So, thank you all for joining us tonight. This is really a big deal.
Yes.
We're going to have to take it a step further, though. 1 in 4 individuals have a behavioral health diagnosis. That's 1 in 4. So look how many of us that it is here tonight. 1 in 4 of us has a diagnosable mental illness, and that is just only the ones that were diagnosed. Think about the folks that aren't even diagnosed, and we know that it's out there. Behavioral health is real. It's here. It's not going anywhere. What we need to do is get educated about it. So that way we'll be able to have courageous conversations within our households. We have to normalize these conversations. It's time for us to, get some heart and get a little courage. And it's going to be anxiety provoking at first. It's going to be scary and you may get some pushback, but we have to normalize these conversations because, again, one reason is the suicide rate in Black children is increasing. Death by suicide for young Black kids between ages 10 and 26, roughly. It used to be number 3. Now it's teetering between number 2 and number 1. We are missing something. We cannot continue with the mantra of children are to be seen and not heard. Let them babies talk. It's stuff that goes on that we may not know about, and they need to be able to trust us as their elders and, share that information with us. So get educated. Start normalizing the conversation. Be careful of the language that you use. Make sure, learn about recovery language because depending on how we word some things, it has certain stigma with it. And if you're saying certain things to me, although you may be coming from a good place, if you're using those kind of stigma associated words, I'm going to feel like crap. And I'm not going to want to talk to you because now you made me feel guilty and shameful. So I can go on, but that's it for me.
Thanks, Tammy.
This last sentence, I guess, mental health is not only depression, schizophrenia, PTSD, because PTSD is a real problem. Depression, schizophrenia, anxiety, PTSD, that's not mental health. Those are mental illnesses. And that we need to make the distinction that what we need to be, not need. I think what would be helpful is if we continue to set our sights on mental health, which is about balance and connection. So no matter when we have these conversations and with whom and about what, the aim, I think, is best served by going in a positive direction about what's the best thing here that we can come up with. What does balance look like? What does inclusion look like? What does I love you anyway, what do you need look like? But mostly it is, let's talk and think and shoot for mental health and not start at the mental illness place. And mental health is about balance and connection.
Tammy Brown, Dr. Sean Garrison, Dr. Candy Winfield, thank you so much. This has been an amazing conversation. I see we have received many thank you posts on Facebook. I know that if we were in a room, there would be a standing ovation right now because you all were amazing. So I know people want to drop your emails and how to get in touch with you in the chat. And I see Nadia has joined us. And so Nadia, I'm sure we heard about resources. Thank you so much for inviting me. Tunnel Light is just extremely happy to be a part of this discussion, and we want to be a resource as well. So thank you so much for inviting me. This was an amazing program.
Awesome. This was an amazing, amazing conversation tonight, and it was very interactive, and I think we all certainly could appreciate that. I'm just thinking, I believe this conversation probably could have continued for another hour or so, very easily. I'm so happy that we were able to address so many of the questions from the audience. And certainly thank you to the panelists for sharing even some of your own personal experiences. Again, thank you to our moderator for driving this candid conversation and to our 3 expert panelists. We appreciate you spending the evening with the Atlanta Suburban Alumni Chapter. And thank you again to Candy Whitfield and Tammy Brown for joining us for the 2nd time this year. We really appreciate it. And we feel like you are a part of this mental health family, as we've tried to, each month, really drive the mental health message home, and again, just a reminder, I think I heard Candy mention, there is no shame in checking in with ourselves. And just remember, it's okay to ask for help. I am Sabrina Clark, and I am the chair of the Physical and Mental Health Committee. Tonight was actually the 7th of our 8 mental health webinar series. So we have one more to go. And so we will be back here again the 3rd Monday in June to close out the series. And then we will be back in September. I know that Nadia is already chomping at the bit for topics. I think I even heard a rumor this evening that said, wow, wouldn't it be great if we could have this same team back at a later time, so you never know. We may see the 4 of you back later in 2021. I want to say thank you to our mental health webinar series lead, Nadia Barnett, for facilitating the series. I'm just proud of how quickly she was able to pivot in the midst of a pandemic. I'm sure she's probably had her own amount of stress, going from a once a year in person mental health event to an every month virtual event. And so we've learned, we've stressed, we've probably even cried, but we certainly, we prevailed, and I'm very proud of this series. In closing, I'll just say, please take a few minutes to complete the evaluation for our attendees, as well as the panelists. We would love to hear your feedback. We want to know, what we're doing, where we've done well, where there's room for improvement. We're certainly looking to, take this series to the next level. For anyone that may have joined us late, you can always replay the recording. You can find it on our ASAC YouTube channel and replay it at your convenience. With that, I will bid you a good evening, and remember, it's okay to ask for help. I'll ask all of the panelists to just hang
Stay
in
on
here
for a
with us for
minute.
just a few more minutes.